All right, so my name is Emma. I'm a fourth year medical student. I'm kind of winding down now. And today we're going to talk about urinary tract infections. So it's a little bit internal medicine. It's a little bit kind of nephrology. We're going to talk about a lot of different things in the next hour or so. I do this time have one specific case for you. So we'll kind of go through that, talk about the presentation and kind of how we can hone in on a diagnosis. All right. So let me share this for you guys and just, be honest and kind of let me know where you guys are at in terms of your knowledge about urinary infections. All right, so I'll end the poll there and share the results with you guys. So it looks like most of you know something or you know a little, and some people know some. Nobody says they know a lot. I would make you guys present if you did. But it looks like, you guys, the majority of you kind of don't know a lot about urinary infections, and that's completely okay. Nephrology and kidney stuff can be kind of challenging topic for students, so we'll kind of take this head on. We'll kind of keep it simple and try to have a little bit of fun as well. All right, so here is our kind of outline for today. How we're going to attack this session basically. So what we'll do is one case. We'll kind of go through the case details. We'll talk about the physical exam findings. We'll talk about pertinent labs and imaging. We'll go through a differential. Then we'll talk about that assessment and plan. And then afterwards, we'll kind of go into the discussion of the pathology. Before we even get to any of that, we are going to have a kind of an introduction about urinary infections, so you guys can have a little bit of context before we kind of just jump right in. But no fear, I will give you guys kind of a little bit of context, before we get started. So what I'm going to ask you guys to do. So first, I'm going to put into the chat here. There's the link that you guys will need that has the SOAP note for you guys to fill out, and we'll kind of talk about the different sections of the SOAP note and what it kind of consists of and what you should be filling out throughout this session. And I'm going to ask you guys to be, active participators, whether it's unmuting yourself or typing it in the chat or, whatever. There's no dumb answers, no dumb questions. The more active you participate and the more you're sort of held accountable, I think that you guys will learn more in that regard and not just kind of sit back and absorb information. All right. If you were with us last, or I guess 2 weeks ago, I didn't present last week. This is our foster dog. He's kind of a pain, but he's very cute. And he almost exclusively poops in the house. So that's my fun fact for you all. You can leave him outside for 30 minutes and he'll immediately come in and poop on the carpet. So that's fun. All right. Okay, so here's the SOAP note form. And SOAP itself is an acronym, and we'll kind of briefly go through it. You guys may be familiar with this from some of our other sessions. There's kind of SOAP, and it stands for subjective, objective, assessment, and plan. Okay, so what the subjective part is things of which are, no secret, subjective. So things that the patient tells us. So it's the history of present illness, why they're presenting the way they are, or presenting to the ED, or presenting to, or why they're admitted, or, why they're presenting to clinic. And then review of systems is all the things that is pertinent to the chief complaint itself. So if somebody comes in with burning when they pee, we might ask them about if they have fever or chills, or if there's blood in their urine, or things like that that are kind of pertinent to what's going on at the time. And then objective are things that we kind of find. So things like vital signs and the physical exam findings. And then finally, assessment and plan, that's kind of, what's going on. So say somebody comes in and they have hypertensive emergency. That's kind of what we think is going on. That's our diagnosis. So that's our assessment. And what our plan would be is to give IV hydralazine, or, what hydralazine, or, whatever we would do at the time in order to treat that assessment that we found. Or if somebody has, newly diagnosed diabetes type 2, we would say, start metformin 500 milligrams every day. And then we'll bump them up to twice a day, or, whatever. So that's kind of what we're going to do. We're going to list all the things that we're going to address, and then what we're going to do as a plan for them. So I hope that makes a little more sense now. And in case you missed that, let me put the link one more time into the chat. There it is again. So that has the Silk Note form for you to fill out. And then also it has the quiz at the end, and I made it very easy for you guys. It should be a very easy quiz. And somebody out there answer me. When I say that these quizzes are easy, do you guys in fact think that they're easy, or am I blowing smoke right now? Okay, good. I'm not trying to make, this super challenging for you guys. I want you to learn things. There is one or two questions that may challenge you, because, I'm not always throwing softballs. I want you guys to still learn stuff. But, my goal for you is that you get it kind of done in 1 to 2 attempts, and that, watching the session is kind of good enough for doing those quizzes. So I'm not trying to make your life any more difficult. I know you guys have classes and tons of other things to do. So so the first thing that we're going to kind of talk about is this idea of urinary tract anatomy. And we talked a little bit about this last week when we talked about acute kidney injury, and last week meaning last time you guys saw me. But and this is the same image that I gave you, is we kind of talk about 2 different parts of the kidney. We talk about the renal cortex and the renal medulla. And if you guys remember, there is something of which is kind of the functional unit of the kidney. Do you guys remember what that was? Awesome, the nephron. And that's where we talk about a lot of the physiology that is behind sort of the kidney itself. So good job. And now what we're going to kind of talk about, and what we're going to kind of focus on, and we're really going to kind of keep it simple in terms of anatomy. And we're going to kind of delineate the upper and lower urinary tract, because, there's a lot of people of whom use urinary tract infection perhaps out of context, because when you guys think urinary tract infection, you're probably thinking bladder infection. But when we say urinary tract infection, that is pretty broad. That's kind of an umbrella term to say that's an infection anywhere in the urinary tract. Okay, and the way that we're going to delineate this is basically the bladder, urethra, and in women, the vagina, that will all be lower urinary tract. Okay, and then in men, obviously the prostate is involved as well in the lower urinary tract. And then when we talk about upper urinary tract, these are things like the ureters and the kidney itself. And when we kind of talk about the kidney, we talk about the renal pelvis, because we know that in the renal pelvis, there is structures that can become infected. That's called pyelonephritis. Okay, so there's lots of different things that kind of can occur in terms of pathology that's not necessarily an infection. For instance, in the ureter, we can get kidney stones. That's called nephrolithiasis. But you're going to see that based on kind of the area, we have different infections. So if we have an infection of the urethra, that's urethritis. In men, if we have a infection of the prostate, that's prostatitis. Of the bladder, that's cystitis. So it's looking up for you guys. It's getting easier, hopefully. And then if we have an infection of the renal pelvis, we call that pyelonephritis. Okay. And we talked a little bit about the vagina, but also we can have vaginitis as well. We see vaginitis sometimes in postmenopausal women of whom don't have estrogen, so you can get atrophic vaginitis in that regard. But remember that itis kind of suffix indicates inflammation. So that's really what we're seeing in all of these things. Okay. So that's a kind of brief introduction to kind of a little bit of syntax, but also kind of some anatomy as well. So this is a lot of what I just talked about here, but if we remember, back to when we talked during the acute kidney injury talk, there's a few functions of the kidney that are crucial. And we know that we have two kidneys, but we shouldn't take them for granted. And kind of drown them in whatever. Ibuprofen and high blood pressure can certainly hurt the kidneys. But what are the functions of the kidneys? Things like formation of urine, hormone secretion. We know our friend EPO is secreted from the kidney itself, and that's a stimulus for red blood cell production. So the kidney can really sense oxygen tension. When that's low, the stimulus for EPO is released. Also renin, that's part of the renin, angiotensin, aldosterone system that is kind of regulatory for your blood pressure, blood volume, and such. Then ADH, which is antidiuretic hormone. So when we're volume down, antidiuretic hormone is secreted, which causes the body to really retain water to bring up blood pressure. And then all of that kind of is involved in blood pressure regulation. And then we know that also there's kind of that acid-base balance component as well through secretion of hydrogen ions and resorption of bicarb. Okay. So let me clear all those notes, and we're going to focus on the image on the right. And we kind of talked about some of this, so this should be fairly simple at this point. But when we really talk about these different parts of the kidney, in the bladder, and really the urinary tract in general, what we're talking about is this idea that the bladder is becoming colonized with bacteria. So how does this happen? Do you guys know how it happens? Where is this bacteria coming from? Putting things into it certainly can, yeah. So foreign bodies in the vaginal canal, outside environment, good. Think close proximity. Yeah, go ahead.
I was gonna say, could also be lack of hydration as well that cause it, or also dark environments as well. Basically cold, dark. Okay.
Mm-hmm. Good. And then there's one I'm kind of thinking of very specifically. So we see this in perhaps in pediatrics sometimes, due to kind of the mechanism of not necessarily knowing how to wipe properly. Yeah, holding in pee, that can definitely cause the bacteria to kind of colonize the bladder. There's one thing specifically I'm kind of looking at. Think about anatomy. What is kind of posterior to the bladder? It's not in this image itself. Yeah, wiping back to front, sure. And what that basically means is that enteric bacteria from the actual rectum, from the colon, is getting into the urethra and the bladder. And for women, we often talk about women, being more susceptible to urinary tract infections because they have a shorter urethra. Men don't often get these, but when they do, they tend to be worse, and that's considered a complicated UTI, especially if it's sort of involving the prostate, so prostatitis. So what we're kind of seeing here is kind of this bacterial colonization. And in terms of if there is a bladder puncture, we certainly can get an infection, and they could get septic because of that. And if we're getting kind of septic because of the bladder or because of a urinary source, we often call that urosepsis. Okay. And tell me a presentation in an older person that you guys would want to be kind of suspicious for urosepsis or for a UTI in an older person. Yeah, good. Confusion. Yeah, I mean, we often call that altered mental status. So if they come in and they're confused and they, were normal yesterday, obviously we want to think about neurological things, but we also want to think about things like a UTI. So good job. Then when we see that bacterial colonization, we see that it also kind of ascends the ureters and can cause pyelonephritis. And that's kind of an infection of the renal pelvis here, the renal parenchyma. And then we also kind of talked about, a couple weeks ago, we talked about acute kidney injury. So that acute kind of, that acute actual injury to the kidney. And I have a slide here next to kind of remind you guys of this. And this is kind of this acute kidney injury slide that was from virtual rounds on the 2nd. But remember, when we classify acute kidney injury, we have 3 ways of classifying it. And remember, we kind of can classify it as pre-renal, meaning before the actual renal system, intrinsic, and post-renal. Okay, so when we think pre-renal, remember we talked about hypovolemia and decreased volume. When we talked about intrinsic, we talked about things like ischemia and nephrotoxins, often kind of in the way of contrast, NSAIDs, and different like chemotherapy drugs like cisplatin. Then post-renal, that can be in the way of a bladder outlet obstruction. We often see this in benign prostatic hypertrophy. That was a question on your guys's quiz on the 2nd. So someone of whom has, a sort of obstruction to urine flow out of the actual bladder, then that causes a problem. And that can cause a post-renal acute kidney injury. Okay, and remember, we kind of use the FENA as our marker when we calculate that to determine whether that's pre-renal or intrinsic renal failure, if it's kind of a muddy presentation. And Adam said this happened to my uncle. He complained of stroke-like symptoms, but ended up being a UTI. Yeah, that's always kind of in the differential, especially if somebody comes with acute delirium. Usually that's an easy thing to do would be to, get a urine and kind of rule that out or rule that in, or, even if they are presenting with that, most people will have a low threshold to kind of work that up anyway to make sure that they're not having a stroke. All right, and here's kind of our algorithm for, acute urinary infections. But the biggest thing that we're going to kind of talk about here in this slide is not even this kind of, tissue biopsy here where we see all these white blood cells in the parenchyma of the kidney. Not even that, I just put that because it's kind of cool and it's kind of academic, but, we're never getting a biopsy of the kidney in order to discern these things. But basically what we're seeing is a patient, is coming in with fever, flank pain, nausea, vomiting, and they have CVA tenderness. So when we hit, the CVA, the costovertebral angle kind of on the back below, around the area of the 12th rib, what we're seeing is, those people are pretty tender. So what we're discerning from this actual diagram is, does this person need to be hospitalized? Is there complications? So if the patient doesn't need to be hospitalized, we can give them oral antibiotics, kind of send them home and follow up. But if there is complications, things like they're immunosuppressed, they're pregnant, they didn't respond to antibiotics in the past, then maybe we do want to actually admit these patients. I mean, here's some kind of indications for hospitalization, things like age, if they're septic, if it's persistent, if they're not able to take oral pills, that's important as well. They'll probably need to be admitted because they have intractable emesis. Then the next thing is, we'll give them IV antibiotics, obviously, but we can get a culture, probably give them IV fluids and get their fever and pain under control. Okay, so that's the biggest thing that I kind of wanted to show you there with that algorithm. is really kind of discerning, is this complicated or is this not complicated, and kind of going about it that way. And here is some, here's another slide that kind of touches on the same thing. So when we talk about, complicated versus uncomplicated, it's often important to know what normal is. Normal is kind of immunocompetent patients. They don't have any comorbid conditions. They don't have urologic abnormalities. So like no stents. They don't have polycystic kidney disease. They haven't had a transplant. They're, not pregnant. They're fairly young. And then, we think if we know that, then we know what the opposite of that is. Things like them being pregnant. They had a history of urinary tract infections. They're immunocompromised. So maybe they're undergoing chemotherapy, or they're on steroids, or, they have HIV, and maybe they have AIDS as a result of that. They have diabetes, which makes it complicated because they don't heal as well. They have chronic inflammation, metabolic syndrome. And then obviously those urologic abnormalities are here too. So things like if they have a stent, they have a history of nephrolithiasis, if they have a catheter that's indwelling, those are all risk factors that make an infection complicated. And for this, we talked about a few of these things, but I want to kind of draw your attention to this idea of, is this person septic? And kind of these different things. So we want to think about things like urethritis. These people usually have discharge. And then we also kind of want to discern sexual history in a lot of these people, not just because of urethritis, so things like gonorrhea and chlamydia, but also for young women of childbearing age. Often women can get urinary tract infections and cystitis post-coitally, so after sex. It's fairly common. And for those women, what we do is we tell them, go ahead and make sure, be meticulous. So yes, drink a lot of water, but pee after you have sex. Okay. And then obviously checking that sexual history can be important. Do you have any new partners, risky sexual behavior, things like that. Obviously making sure if they're septic, that's a big thing. So things like high fever, are they tachycardic, is their respiratory rate up, is their white blood cell count really high or really low? And then I want to kind of draw your attention to this urine dipstick here. The things that we're looking for is positive nitrites, and we're looking for leukocyte esterase. And then, that can kind of tell us that a urinary tract infection is, likely. If it's negative, it's less likely. It might be something else, or they kind of eradicated it, or you'll find a lot of people will be like, oh yeah, I got burning when I pee, and then I took my old amoxicillin, or I took my old penicillin. So that could potentially kind of blunt the urinary result of the dipstick when we look at it. And in those cases, we may treat empirically if we think there is a clinical suspicion for these things. So that's another kind of algorithm for these things. So we'll kind of keep going here, because this is kind of a repeat of the last slide. Let me clear all this. All right, and we're to the case now. So I would love it if somebody would read the case.
I can go ahead. Forgive me if I mispronounce any words. A 44-year-old.
That's perfectly okay.
Okay. A 44-year-old female with a PMH of nephrolitis, kidney stones, SP stenting in 2019 presents with a 48H history of flank pain. Her spouse is accompanying her, of whom reports some confusion that was developed over the last 2 days. The pain is sharp with the R flank, which radiates to the groin. The patient notes that it feels as though I cannot find a comfortable position. The pain is currently a 10 out of 10 and is associated with intermittent bouts of nausea and vomiting, which she denies abdominal pain, diarrhea, dysuria, and hematuria. Forgive me.
Okay, perfect. No, you did great. So a few things that you guys may not kind of be aware of, and probably shame on me for abbreviating these things. I just kind of naturally do them now. It's a habit. But for this is past medical history. Okay. If you see anybody put this means kind of status post. So after, basically, that's 48 hours. And what else? Anything else you guys not sure of what it actually meant? Yeah, hematuria. Good. So if you're unsure of something, we can kind of break down the word. So heme meaning blood and urea meaning urine. So blood in the urine. Okay. And this one is another urinary symptom, but this one is kind of painful urination. Right flank that's just right flank, abbreviation, right and left. So the flank is kind of the back area over the kidney, basically. All right. So what I want you guys to do now is kind of pull out your pointers, if you can find them, or tell me through the chat. But let's be very specific this time, not to highlight things that may not necessarily be incredibly important to this person's differential diagnosis. So what are the things you guys want to kind of hone in on at this point? Confusion. Good. Perfect. So we got 2 votes for the confusion. I agree.
The nausea and vomiting.
Absolutely. Good. Yeah, the burning with urination, pretty severe pain. Good. It radiates to the groin. Great. What about the vital signs? Anybody see any that they're worried about? History of nephrolithiasis. Good. So they have a history of kidney stones. Yes. And they have a fever. Good. They're tachycardic. Excellent.
The heart rate is pretty good though, 114, as long as it's up under 120, if I'm not mistaken. But what about the respiration rate? 21. Is that elevated or?
Yeah, that's pretty elevated. You'll see kind of a range of normal depending on who you talk to. The patient, in this instance is probably tachycardic because they're febrile. So we kind of look at the vital signs in context, basically. But good. I think you guys are kind of honing in on the right things. There's one thing that I think you guys missed in their history. That is important. Nice. I think Josh just underlined it right as I said that. Good. I'm kind of honing in on, and obviously I'm honing in on because I wrote this case, but this is going to be important. When remember our slide a couple slides ago when we talk about what makes something complicated, if they have a urologic history, okay? And then there's one other thing this patient may have when we consider, does this patient need to be admitted or not? And somebody kind of underlined it as an important thing, but what is it, do you guys think, that might make this complicated? Or, they may need to come into the hospital because, they can't take oral antibiotics. Yeah, the nausea and vomiting. Good, exactly. If we kind of, if somebody's vomiting and can't keep anything down, we would be doing them an absolute disservice to say, here is some, here's a fluoroquinolone, go treat this at home, because they can't keep it down. It might even become septic if they're not able to treat this, urinary tract infection.
Couldn't you combat the vomiting or the nausea with like Zofran or something?
Yeah, I mean, we certainly can. If they have a risk factor that is, needing them to come into the hospital, they may need to come anyway. But yes, we can give them something like Phenergan, Zofran, things like that, and likely we will. But we wouldn't say just because they are vomiting they need to come into the hospital. But if we give them Zofran multiple doses and they're not able to, or they're still vomiting, they have an intractable vomiting, meaning it's not able to be treated, and then we want to bring them into the hospital.
And if they're presenting with emesis, how severe does the vomiting have to be, before it's like considered like okay, or is it just like a one-time,
Yeah, so that's a good question, and you know it certainly depends. So the way I look at it is somebody of whom is vomiting, not able to keep down fluids. It's intractable to our attempts to fix it, whether it's IV fluids and ondansetron, so Zofran, and they're not getting any better. They're still vomiting. You know, maybe they still have dry heaves. Things like that. Their volume deplete. That's another thing as well. It could be, you know, pretty volume deplete as a result of that. And a way that we can kind of, you know, discern that is on the physical exam, but also due to the blood pressure as well. She's like fairly normal. I wouldn't call that hypovolemic by any long shot here. Okay. All right, so let's keep going here. Here's the physical exam finding. So we always kind of do a general exam, and you guys will get in the habit of doing this too. I'm kind of looking at the patient saying, you know, what do they look like? Are they in pain? You know, if somebody comes in and they're like, oh, my back hurts so bad, and then, you know, you see them kind of squirming in their chair and you know, they're in a lot of pain, then, you know, that might tell you something. Or, you know, if they say they're in a lot of pain and they walk normal, then that might tell you something else. But you know, this kind of goes secondary to, that's what this means. Mild distress secondary to pain. And then in terms of the HEENT exam, so head, ears, eyes, nose, throat, this patient has dry mucous membranes, probably because of the vomiting. So we definitely want to, you know, give this patient some fluids. They are tachycardic, but no murmurs, rubs, or gallops. Their lungs are clear. Their abdomen has no tenderness, but they have CVA tenderness. So I should have put a little diagram for you guys, but here's my poor interpretation of somebody's back. And here's her neck. This is awful. So we'll see kind of the 12th rib about, you know, this area maybe. And, you know, we obviously know we have the cervical, thoracic, and lumbar spine. The costovertebral angle is kind of, you know, right at this area of the 12th rib. So we're going to do this test. It's called Lloyd's punch. And, you know, you put your hand basically up against their back. So their back would be here. And then you kind of, you know, punch it. You don't like go to their back and like punch them. I remember when I was a first or second year in school, or like professor made that like abundantly clear, like not to punch somebody. But you're putting your hand there and kind of giving them a tap, because that sort of reverberation from that that hit will kind of you know, cause tenderness if there's something going on. So my question for you guys is, what things do you want to think about if somebody has tenderness in that area? What pathologies? Good, certainly kidney problems, but which ones? The patient has a history of one of them that we want to think about. Yeah, Pylo, good. Madeline, and stones, exactly. Those are the two that I was thinking about, and I think you're absolutely right. If somebody's squirmy and you know, can't find a comfortable position, that makes me think stones. But if somebody's febrile, that makes me think infection. Okay, so this is how we're kind of synthesizing all this information to make sense of it, to make it fit our sort of our clinical judgment. The patient has a little bit of edema. But my question for you guys now is what tests are you ordering? You guys are in charge. You get to click the buttons on the computer. What do you think? UA, good. I agree with you, Madeline. What are you looking for on your UA? So CBC, good. Adam already knew what I was going to ask for. You're looking at WBC, I agree. And that can tell us about sort of their status in terms of sepsis, nitrites, and leukocytes.
Or X-ray?
What are you looking for in the X-ray?
Well, I'm guessing if you're saying the pain or something, I'm going to try to look for any type of stones or abnormalities if possible.
Yeah, exactly. If we have a clinical suspicion for stones, the best test for that would be an upright KUB, kidneys, ureter, bladder X-ray. Do we think that this patient has a kidney stone?
If I'm not mistaken, I think we do. But what about a HIDA scan? Doesn't it show like the full functions and stuff to make sure it's functioning properly, or?
So HIDA scan is for the gallbladder. So the HIDA we usually use for if somebody has an issue with the gallbladder, gallstones, and they may have choledocholithiasis. We might use a HIDA scan to see the absence of the filling of the actual gallbladder, and that clues us in that that might be an issue with the gallbladder there.
Okay.
Okay, so let's see. Madeline said culture. I agree. Yeah, we want to send that for a culture. And the good thing about it is sometimes it reflexes to a culture, and that's great because then we don't have to do it. Because if there's certain parameters that are positive, we'll want to send it, culture it, and then in a few days, our friendly neighborhood lab techs will say, this is what's growing, this is what it's susceptible to. So if we start them empirically on antibiotics and it's not susceptible to that, we'll want to change the antibiotics to what it is in fact susceptible to. And you may ask, well, how do they know what it's susceptible to? So what they do is they sort of get a petri dish. And we have our agar plates, we have blood agar, we have chocolate agar, and in some instances, which is hemolyzed red blood cells. And what we're doing is streaking the urine on the plate, and we're waiting for it to grow. And then what we're doing when it finally does grow is we drop some antibiotics on there. And then what we're looking for is if there is a lack of growth, so an inhibitory concentration kind of around that antibiotic disc. So you'll see it kind of grows up to a certain point and then stops. But if it grows all the way up to this disc, that means it's resistant to that antibiotic. So I always thought that was cool, and nobody really tells you what that means, if something's susceptible or resistant. So there's your fun fact for the night. So all right, what tests? Anything else are you guys looking for? I know you guys said CBC. We got a UA, which I think are all great. Anything else?
Is the UA similar to like a dirty catch or like a clean catch?
So yeah, in this instance, if this person, they're fairly young, so you would always want to get a clean catch if you can. There's really no instance where you would prefer kind of a non-clean catch over a clean catch. If they're sick, you might just cath them and get an in and out cath and do it. If somebody's sick and is on the sort of verge of urosepsis, you wouldn't want to leave that urinary catheter in and cause another reason for them to be septic, basically. And that's what we kind of look for, especially on the unit. When somebody has a new fever, how long have their lines been in? How long has their central line been in? How long has their arterial line been in? How long has their catheter been in? Where can we look at for sources of infection? Okay, so here's some tests for you guys. Nobody said a CMP, but here you go. It's here anyway. So what we see is an increased BUN to creatinine. So it kind of points us in the direction of kidney, but we thought that anyway. And besides that, we're also kind of seeing a low CO2. Why does this person have a low CO2? Yeah, high respiratory rate. So they're blowing off CO2. And as a result, the CO2 is dropping low. So would that make them acidotic or alkalotic? Keeping in mind that CO2 is an acid and that the acid is low, would they be acidotic or alkalotic? What do you guys think? Yeah, they're alkalotic. Good. You guys are handling those hard questions well. And those can be very challenging, those acid-based questions. So good. Remember that CO2 is the respiratory acid. Bicarb is kind of the kidney's compensation for acid base, and that's obviously a base. So for blowing off CO2, that is a respiratory alkalosis. But we can get more studies to discern that, maybe a blood gas. Their lactic acid is high, so they may be in fact acidotic. If their pH is low, this may be kind of a compensation for an acidosis. So if we look at it, we may say, oh, okay, they're breathing fast, the CO2 is low, maybe this is a respiratory alkalosis. But if we got a blood gas and then, we saw that they're acidotic, we might see that that's a compensation. If it wouldn't take too long, could you go over the significance of BUN and creatinine? Yeah, so basically what that means is the BUN is the blood urea nitrogen. So basically we look at urea and creatinine as waste products for the kidney. When they start to get high, we're saying, okay, this is basically a way that we can look at the actual synthetic function of the kidney. So that's what I'm going to kind of leave it at. I don't want to kind of cloud your, your judgment at this point. But what we're looking at here is that ratio, the BUN to creatinine ratio. And usually if that's greater than 20:1, that kind of points us in the direction of, what's going on with the kidney. Okay, and good. So let's keep going here. We're going to talk about the CBC as well. And we see here that this white blood cell count is high. So our kind of antennas are up here in terms of this patient having an infection. Their hemoglobin and hematocrit looks okay. Their platelets look good. So what imaging do you guys want to get? Or what other tests do you want? I know Madeline said UA. Madeline's like, give me the UA. I'll give you a UA. Anything else? Oh, you guys are getting a CT too. Spoiler alert. So here is the urine studies. So what we're looking at here is we're looking at a urine dip. So we get the, we get the urine, we kind of dip it, and then we look at this. And this is certain parameters are read at certain times. The last of them being leukocyte. Usually that's read at 60 or 90 seconds. I can't remember. It's been a long time since I did that. But what we're seeing here, and I circled the results for you, is negative glucose. We're saying a normal urine urobilinogen. And if that urobilinogen is high, it might point us in the direction of problems with the GI tract. Same with bilirubin, that's negative. There's a little bit of ketones. It could tell us that the patient's a little bit dry. The specific gravity is high. That tells us, how concentrated the urine is. There is some blood in the urine, about 3+. So blood in the urine would want us to sort of kind of focus on which pathology? Especially with their history. Yeah, stones, good, exactly. And those stones could certainly be in the ureters as well. And the pH level 6.5. There's trace protein, and the ones that I know you guys were looking at here is this urine nitrites, which is released from gram-negative organisms, often the Enterobacteriaceae bacteria that are sort of responsible for UTIs. And then there's a pretty high concentration of leukocyte esterase. Then we do a reflex urine microscopy, and we see this. What is this? Does anybody know? Is there any lab techs out there? It's okay if you guys don't know. It's kind of tough. This is actually, let's break it down. Crystals. I'm a lab tech, but not that kind. Oh, what kind of lab tech are you, Madeline? You don't work in the hematology lab. You don't do UAs. So basically, what we're seeing is sorry, that's the puppy barking. I knew he would do something bad. But what we see for when we're looking underneath the microscope is our white blood cells kind of look granulated like this. Okay, so we see kind of these granules in it. And then when we see red blood cells underneath the microscope, they're a little bit smaller, and we see that kind of biconcave shape. So that being said, do you guys think these are white blood cells in this down here, this thing that we're seeing, or red blood cells? Yeah, good, excellent. This is white blood cells, and we see them kind of in this shape together, and this is called a urinary cast, and it's pretty pathognomonic for one specific type. So what we're seeing so far, guys, is white blood cells. We're seeing a fever and we're seeing flank pain. What are you guys kind of suspicious of at this point? What is kind of high on your differential? UTI certainly, but which type? Remember, UTI is really, really broad. What part of the kidney are we kind of looking at here? Upper, certainly. Anything specific? Do you guys remember? Think of that high fever that kind of hones us in on it, and the flank pain. And in the meantime, I'm going to give you a CT scan. And I like the CT scan because when I put it in my slide, it lit up and it showed me exactly where the issue was, like a radiologist, which is great. So what it's highlighting here is kind of, remember on our CT scan, what we see is that bone is going to be white. Okay, so there's kind of part of the vertebra there. Air is going to be black, and then tissue is going to be kind of gray, so it's going to be kind of in the middle. And here's our friends, the kidneys. So here's one over here, and the other one is over here. It's enlarged. We might see some hydronephrosis, and we see the black kind of inside of the kidney. Is that normal or abnormal? You tell me. Should we see air in our kidneys? Yeah, it's abnormal. And what we're seeing here is this is emphysematous pyelonephritis is what we're saying, and you guys probably read that at the bottom, so it's no secret by now. But if you want to look for a kind of normal comparison, the kidney on the remember, when we're looking at this, we're looking at the patient from the feet up. Okay, so everything's kind of backwards. So what looks like our left is actually the patient's right. Okay, and this is the left, because we're looking at their feet. We're looking up through their feet, basically. So this is actually the patient's right kidney. This is their left kidney. And we're looking at this left kidney, and we see it's fairly normal looking, especially when it kind of goes through those different cuts. We don't see any hydronephrosis. It's kind of normal inside. We don't see any stones in the ureters, because we can kind of follow the ureters down as we go through the cuts. But here we kind of see some inflammation. We see air, and that's definitely abnormal. Okay, good. So what is our differential diagnosis, guys? What are we calling this? What are we putting our money on? We're going to come up with this together, and we'll see how many we can get right. It's like Wheel of Fortune, I guess. Oops, I stopped sharing with you guys. Oops. I feel like I'm old. Where did it go? Okay, here it is. All right, are you guys able to see that now? Again? Okay, perfect. Good. Did it ever go away, or is it just for me that I couldn't see it? Oh, okay, it went away. Awesome. So what is our diagnosis? What are you guys going with? Remember, we put our assessment and plan number one, and then what we're going to do for it. So what are we calling it? We don't have, yeah, good, exactly. Yeah, you guys are calling it emphysematous pyelonephritis. I would even, you can even say pyelonephritis. I think that's perfectly fine. So how do we treat pyelonephritis? From our introduction slides, remember, what do we want to do? And you guys don't have to come up with specifics, but I want to kind of hone in on a plan. Good. We want to do fluids. What kind of fluids are we wanting to give them? Antibiotics, absolutely. We want to give antibiotics. Good. What about for the nausea and vomiting? Anything? Pain meds? Absolutely. We want to manage their pain. Pain management. Probably give them morphine. This person's in a lot of pain, pretty sick. For the antibiotics, we can give them a fluoroquinolone. What else? Anything else you want to do for this patient? Who should we talk to? This patient had a stent put in on their for their history of kidney stones, probably put in their ureter. Who do we want to talk to about that? Do we just, yeah, we want to, and actually it's a urologist. It's confusing. We'll consult urology. So basically the way to think about like nephrology and urology is like more of like function, whereas nephrology is more structure, if that makes any sense to you. I know it's confusing. Anything else you guys want to do here? Yeah, anti-nausea meds. I agree with you. We can give her some Zofran. Zofran and all of these things, fluids, antibiotics, Zofran, PO or oral.
Well, if they're not,
that's the same thing, PO or IV.
No.
Sorry, I said the same exact thing. Yeah, good. I agree. And what is kind of her risk factor for IV other than her being very sick? MSS. Yeah, exactly. And do we want to send this patient home or do we want to admit this patient? That's my last question for you guys. Yeah, good. And why do we want to admit? So not all things IV need to be admitted, because you guys will find, a lot of things we can do in the ED. We can give them their first dose of antibiotics and send them on their way, or we can give them IV fluids in the ED and then discharge them. So not all things IV need admission, but what is this patient's risk factor that sort of necessitates that they need to come into the hospital?
I want to say that pain.
Yeah, so pain for sure, and it's a complicated UTI. Good, Sammy. What makes it complicated? Yeah, the stent. Absolutely. Good job. So the stent for sure. And if this patient was pregnant, that would be an issue. If this patient was immunocompromised, remember that would be an issue as well. If this was an older gentleman of whom had prostatitis and was confused, that's also complicated as well. Okay, so good. You guys did a good job kind of discerning these things. I want you to kind of make these management decisions and kind of think about this stuff, how we, not only what it is, but, how we kind of go about it. So I put admit, we want to give IV fluids, probably normal saline. We give IV antibiotics, and then upon discharge, they'll finish those out orally. So it's not like, we're giving everything in the hospital. Madeline was absolutely correct. We're going to do a urine culture and follow up with those sensitivities to see what that, bug is sensitive to. We want to consult urology because that patient has a stent in, to see if, the stent could have been a causative factor of that patient having pyelonephritis. Why did they have pyelonephritis in the first place? And we'll talk about causes of it here in a few seconds. So good. So now, what is pyelonephritis? AAFP kind of calls it this infection of the upper urinary tract, and primarily the renal parenchyma and the renal pelvis. So remember, the renal pelvis is kind of this part right here. So remember, our kidney or our ureters kind of come out like this. We're primarily kind of talking about here. And how do these people present? The way that you should kind of think about it, and the things that make me think about it, is flank pain, yes, but not all flank pain is pyelonephritis. It could be kidney stones, it could be back pain, it could be regular back pain. So we have to kind of discern what is what, basically. But the thing that kind of points to it is this high fever. They can have some urinary symptoms, they may not. They may just have fatigue. We had a guy fairly recently that came in, was like super altered, didn't have any flank pain, but had a fever of 102 point something, and was just very confused. So the first thing we did was check a urine, and they're pretty volume depleted, pretty sick. So not all, pyelonephritis is flank pain. So we have to kind of discern also and kind of look at the big picture and kind of piece it all together. So what kind of causes this? And remember, we talked about a lot of this is sort of bacteria, of which is kind of local to the colon. So things like E. coli, things like Klebsiella, Staph saprophyticus. That's we often see that in women. That's women of childbearing age of whom are sexually active. We can also see Candida species, so that's more of fungus infection. We can see vaginitis in that regard. But here's the kind of Enterobacteriaceae, the Proteus, Enterobacter. Rarely we see these two, kind of the ureaplasma and or the Pseudomonas. But the ones that we see overwhelmingly are these kind of E. coli and Klebsiella. And similarly, E. coli is the most common cause of the emphysematous pyelonephritis as well. So kind of those anaerobic bacteria of which produce air, therefore you see the air kind of on the scan as well, and they get pretty sick. All right. So here's our risk factors. We kind of talked about this again, but or here it is again. And what we're kind of looking at here is the big ones. So age, remember the extremes of age. So babies and elderly. And if you ever see it, if a baby comes in with sepsis, they kind of get the full workup because those babies shouldn't be septic. They'll often get a lumbar puncture. We'll get a urine. We'll get lots of different things to kind of discern what's going on with that baby. Same thing with elderly patients, especially if they have altered mental status. And then remember, the kind of anatomic or functional abnormalities, this one kind of being pretty important, the vesiculo-uretic reflux. So kind of urine refluxing the opposite way that it should be going. And that can cause stasis of urine and correspondingly colonization of the bladder of the urinary tract. Foreign bodies, so you guys got that one. Kidney stones themselves, so renal calculi, immunocompromised state. So remember, it's not just the HIV, it's not just the diabetes, but things like sickle cell disease. We can get papillary necrosis of the kidney itself from things like sickle cell disease and get a superimposed bacterial infection. Then things like male sex, that's certainly a complicated UTI. Things like obstruction. Then remember, pregnancy is always one. You saw calculus and you thought of math instead of stone. You had like PTSD from calculus. I know I did. I took like one calculus and I was like, that's it, enough for me. Math is a risk factor for everything. I agree. I second that. Anytime I have to do math, when somebody, I think in one of my rotations was like, how many, cc's are in a whatever, or how many cc's are in a tablespoon or something. I was like, I have no idea. Anything with like numbers is like, I can calculate simple stuff, but like science is my jam. Math is not my sport for sure. But good. And then in terms of complications, the one that we kind of look at is, long-standing walled off infection can kind of create this perinephric abscess. We want to look at sepsis, thrombosis of the renal vein, that papillary necrosis. So kind of infection of the papilla, and then renal failure as well. You'll see people, sometimes they get pretty sick, wait a while to come in, and then correspondingly have acute renal failure and or chronic renal failure after a while. What is a perinephric abscess? Basically, it's an abscess of the actual kidney because of the body kind of wanting to wall off that infection. So you get an infection like pyelonephritis. And then in order for the immune system and the kind of immunologic cells to want to kind of keep it at bay, you can get an abscess because of that longstanding inflammation and infection in the kidney. So you get basically just an abscess, a walled off bit of infection in the kidney. Okay, and those are usually need to be operated on often. Okay, and we went over this kind of diagnosis and treatment. And so now that we know a little bit more, I want to kind of bring your attention to this kind of block. And this is kind of the things like pain management. So let's manage their pain. Let's control their fever with, Tylenol. Let's give them appropriate hydration. Let's give them a fluoroquinolone, or if they have risk factors, we can give them like Unison, ampicillin, sulbactam, or aminoglycoside. But fluoroquinolones usually are kind of the go-to for that. If somebody is very septic, they might kind of, use Piptazo and Vanc until we really know, and then kind of de-escalate later on once we get the cultures and sensitivities. But a lot of people will use kind of the big guns first and then kind of de-escalate later if they're pretty sick. But that is my last slide for you guys. So before you guys go, I want to relaunch this poll for you. And I want you to, punch in your opinion of what you know about, pyelonephritis, urinary tract infections now. The quiz should be available to you guys on that link that I had sent you before. And if you missed it, here it is again. Go ahead and do that quiz. It's quick. It's 10 questions. You can certainly get credit for coming to the session. And fill out that SOAP note as best you can. You'll have access to the PowerPoint as well in that link. So you'll be able to kind of go along with it and fill in the SOAP note as appropriate to get some of that exposure to medical documentation. All right. So let me share these results here. So it looks like nobody said they know nothing, which I'm very humbled by. It'd be a little sad if you guys still said nothing. So it looks like you guys said a little, and the sweeping majority of you guys said some. So that's great. I'm glad you guys spent your Wednesday night with me. I think I'll be back in 2 weeks. I think somebody's presenting next week, and then I'll be back the week after. But let me stop sharing these results, and I will stick around for a few minutes, afterwards and answer any questions you guys have, whether it's about, match or medical school or applying to medical school or whatever questions you guys have. I'm happy to answer. And otherwise, thanks for coming. I always appreciate your guys' participation, and you guys are always a smart bunch. You're able to answer my questions, so I appreciate that. But have a good night. Thank you all for coming.
Hey, so I asked this question last week to the last young lady who was presenting, but like far as like any other like things that we can do to pretty much boost ourselves to make us much better candidates for med school. I'm doing my bachelor's in psychology with an emphasis in clinical mental health. But I didn't know, like, I know GPA is one thing. I have experience working in the OR, but just anything that you would suggest that I can do pretty much just to push myself over and above, basically. Like, I have a year and a half, so should I start studying for the MCAT or?
Yeah, so it certainly depends on where you're at and your schooling. MCAT is certainly important. I would say the important things are to obviously the MCAT, your GPA, though that's not everything. A lot of schools are looking at kind of this holistic approach, which I think is very reasonable. So things like having extracurricular activities, having longitudinal volunteering experiences, being able to talk about those things as well. Having kind of immersive clinical experiences, whether it's scribing or in the OR, like you said, or what else? EMT, things like that, I think are good experiences to have, so that it shows that you're dedicated to being involved in medicine. I think that those are good things. But yes, obviously MCAT and GPA are kind of those things, those statistics that people use as numbers to kind of as ins or outs, basically. So those are certainly important. as well. But I would say it's kind of the big picture thing. So volunteering, shadowing experiences in medicine, and kind of those extracurricular activities too, that kind of demonstrate, who you are as a person.
Okay. And then at what point do you think I should start applying to med school? Like I said, I have a year and a half left for my bachelor's. Like, should I wait like a few more months before or?
Yeah, good question. So it certainly depends on you and kind of what your ambitions are. Me personally, I took 2 gap years after I finished my undergrad degree, and I wouldn't have changed that for the world. I think those gap years were crucial for me. I got to, work full time. I, moved to Maryland and worked at Johns Hopkins for a couple of years, and I was able to, live my life and, work a job and learn how to, just be a person basically before I started medical school. So it's definitely up to you. A lot of people, will apply the summer of their senior year basically, because applications open in May, and they start submitting anywhere from May to June. So they'll often apply their senior year, and if that's something that you want to do, great. If you want to take a year off and pursue research, you can do that as well. I think that is one of those things that also kind of boosts your application as well if you're interested in
Research?
it. But yeah, you can certainly get involved in research.
Hmm.
Um, yeah, talk to your chemistry department or your biology department. Some of your professors might be able to point you in the right direction of that, and you can kind of get your foot in the door and in terms of doing a little bit of bench work and stuff like that. That's often where undergraduate students start.